Welcome back after your break. And let's continue with the part 2 of this webinar. Now we are going to talking about the rest of the adjuvant treatments options, including radiotherapy, endocrine treatment, biphosphonates, and we will also talk about the side effects, emergency situations, and assessment and management of combination of treatment-related symptoms. Teresa put this slide on, and she has been talking about the different treatments and approaches for early breast cancer patients. Well, what additional treatments might be best for the patients? At the moment, there are many treatments available for early breast cancer, and that's why this slide is so busy. But surgery and radiotherapy are quite common for every patient, and as surgery was already covered, we are now going to move into radiotherapy. Radiotherapy uses high energy rays to treat cancer locally. It destroys cancer in the area where it's given. Radiation therapy in the breast cancer may be delivered to different areas. It can be to the whole breast. It can be a portion of the breast after a lumpectomy to radiate just the area where the cancer has been removed. It can be to the chest wall after a mastectomy, or the regional lymph nodes. And as well, there are different types of radiotherapies. The most common type of radiation therapy is external beam radiation therapy. Post-lumpectomy, whole breast radiation is a standard component of breast conserving therapy. In these cases, radiotherapy is useful to avoid local recurrences. It can also be used, as I was saying before, in combination with other systemic treatments, especially when there is lymph node involvement. In case that there is lymph node involvement, we also speak about regional nodal radiation, and it can be covering either the axillary, paraclavicular, or internal mammary nodes. And it can be done either following a lumpectomy or a mastectomy. Regional node radiation is associated with significant improved progression-free survival, but at the same time, is associated with an increase in radiation toxicities that we will be talking about later. Apart from external beam radiation, there are other techniques that are being developed all the time. One of them is brachytherapy. That is another type of radiotherapy that may also be used in breast cancer, but is not included in the ESMO guidelines, and the use is not general. This radiation, brachytherapy, consists on inserting radioactive seeds into the breast tissue. The most common type of brachytherapy is the intracavitary brachytherapy, when a device is put and left after breast conserving surgery until the treatment is complete. You can see here the ESMO guidelines for radiotherapy in early breast cancer, where it indicates, depending on the situation of the patient, what radiotherapy is indicated. And you can see that the routine is external beam radiation. At the moment, the recommendation we're talking about post-mastectomy radiation therapy to the chest wall and regional lymph nodes is to do it in cases that there is 4 or more positive nodes, unless there is someone with triple negative breast cancer, where 1 to 3 positive nodes is enough to recommend radiotherapy. And I was saying before that there are different kinds of radiotherapy, and the image here is concerning all of the radiotherapies, and as well the side effects that we will explain later. But you can also see that patient experience is affected. And this patient experience is related to discomfort, to treatment duration. We must remember that coming to the hospital every day for radiotherapy treatment does impact the patient for many reasons. Traveling when they may already be feeling unwell, how they travel, because they may not drive after surgery. They have to pay parking tickets at the hospital that, as we all probably know, they are normally very expensive. So there are many things that affect the treatment, not only the side effects of the treatment. We also have to think about the patient options and their preference. For example, the intracavitary brachytherapy that I was giving as an example before is not compatible with breast reconstruction. So if the patient is thinking of oncoplastic reconstruction, that's an option that cannot be considered. Now, what are the side effects from radiotherapy? We were saying that adjuvant radiotherapy is a standard procedure after surgery for breast cancer to reduce the risk of local regional recurrence. So potentially, most of these patients are cured of their disease after the surgery. So we need to really think carefully about the potential side effects of radiotherapy and especially long-term hazards. The development of radiotherapy has led to adapting the radiation therapy more to target the region that needs to be covered, and therefore decreasing the radiation to healthy tissue. But still, it has some risks. The most typical ones are developing of fibrosis or damage, or even the discoloration of the skin. In general, radiotherapy is well tolerated and does not significantly impair the patient daily activities. Acute side effects are common, they are self-limiting, and they normally resolve around 4 to 6 weeks after therapy. And the skin reactions are the most common side effects. Skin reactions normally appear 2 weeks after starting treatment. So it's not something that you see just immediately after you start the therapy. It takes some time. The radiated area normally turns red, as you can see on image A, but it can also change color, as you can see progression in image B. Other common changes are dryness that can follow by flaking or peeling of the skin. And that's the example that I have there on image C. The affected area may also peel over time or blister or weep, as you can see on image D. And the changes on the skin may be accompanied by swelling, pain, numbness, tingling, so all the discomfort. Another thing that we have to think of, and we have already mentioned when speaking about surgery, is reconstruction. Radiation therapy may have negative effect on the cosmetic effect of a reconstructed breast, particularly when they are using implants. So, as is still recommended not to delay reconstruction, we have to consider very carefully the risk and benefits of different reconstruction techniques before doing them. Regarding the affected arm, when there is radiotherapy to the axillary area, it may increase the risk of lymphedema, or people may experience some weakness of the arm. Also, when receiving radiotherapy to the axillary area, there will be armpit hair loss, that even if it can be seen as positive by many of us, it may affect negatively to the appearance and image to other people. It may also cause other general symptoms such as fatigue or sometimes nausea. There are other side effects related to radiotherapy that may develop months to years after treatment. We call them long side effects or late sequelae. And the late sequelae can be divided in 2 groups. The more common effects are on the appearance on the breast, and those that are very uncommon but severe in consequences, as brachial plexopathy, lymphedema, cardiac morbidity. Regarding the long effects in the skin, there is the possibility of permanent changes in the skin, such as telangiectasias, discoloration, changes on the size of the breast. You can see some examples of telangiectasias on the image of the right side of this slide. There is also risk of breast fibrosis. And now if I move to uncommon side effects, there is a possibility of scarring from radiotherapy that may cause nerve damage. And that nerve damage may affect the arm on the treated side. It can develop many years after the treatment. And symptoms can include tingling, numbness, pain, weakness, and it may also cause in some people some loss of movement in the arm and shoulder. It's very uncommon, but people need to know about them. There are other uncommon, but very severe in consequence side effects. The heart and the lungs are routinely exposed to incidental radiation during adjuvant radiotherapy of breast cancer. Radiation dose to the lung can increase the risk of radiation pneumonitis, lung fibrosis, and even secondary lung cancer. If the radiotherapy is on the left breast, it also carries the risk of heart disease, as ischemic heart disease and cardiovascular diseases. These risks are decreasing thanks to the new radiotherapy techniques that are developed to spare dose exposure of the heart, such as the modern intensity modulated radiotherapy or the volumetric modulated radiotherapy, just in case some of them ring a bell. But sometimes these changes may increase the doses to the lungs. There was a study recently done to the quality of life of the patients after different regimes of radiotherapy, and it showed that radiotherapy regimen did not substantially influence the long-term quality of life, with the exception of breast symptoms. Now we're going to move to another treatment, and it's endocrine treatment or hormone therapies. Tumors expressing either estrogen and progesterone receptors are considered hormone receptor positive breast cancers. We did talk about this type on the first webinar. This means that either estrogens or progesterone, or both, promote cancer growth. Hormone therapies try to prevent the cancer cells growing as they work by stopping or reducing significantly the estrogen going to the breast cancer cells. All patients with ER positive or PR positive breast cancer, independent on the HER2 status, should receive endocrine therapy daily for at least 5 years after surgery to block the ER activity or the PR activity. And what endocrine therapy is best depends on many things, but especially menopause status. Extended adjuvant endocrine therapy for up to 10 years or even 15 years is also used and has proven some favorable patient outcomes, but it depends on the patient and their tolerability as well as the risk of recurrence. ESMO guidelines state that there is minimal benefit for the use of aromatase inhibitors for more than 5 years. So that's why the guidelines say to use at least for 5 years. We're going to talk about the two most common drugs. Ones are tamoxifen, and tamoxifen blocks estrogen receptors. And it does bind into the receptors of breast cancer cells and therefore stop growth of the breast cancer cells. This drug can be administered in people before or after menopause. In premenopause patients, tamoxifen is the most common drug used, as reduces the rate by approximately 50% in the 5 first years after diagnosis, compared with people that have no endocrine treatment. When treating a woman prior to menopause, depending on the risk, we may also have to add the discussion of if to treat with ovarian suppression using a drug called gonadotropin releasing hormone agonist, such as goserelin, or if an oophorectomy to remove the ovaries would be beneficial to induce menopause. This is considered in women with quite a high risk of recurrence of breast cancer. In postmenopause of women, the options include either tamoxifen or an aromatase inhibitor, and it can be as monotherapy or in sequence. So we're going to speak a little bit about what aromatase inhibitors do. Aromatase inhibitors are a oral drug, which inhibit an enzyme called aromatase, and therefore stops the production of hormones. And why these drugs are not used in premenopausal women? Well, the problem is that the estradiol level doesn't change, which means that if these patients were without endocrine therapy. And why? After women have been through the menopause, their ovaries no longer produce estrogen, but some estrogen is still made in fat cells and in adrenal glands using an enzyme called aromatase. So, aromatase inhibitors prevent this enzyme from working, so less estrogen is produced. We have some names of common aromatase inhibitors. There are letrozole, anastrozole, exemestane. They all stop estrogen producing. And as I was saying before, they can be taken alone in postmenopausal women, or if a premenopausal woman is using the ovarian suppression, the goserelin drug, they can be used as well in combination with the goserelin. And goserelin is not an oral drug. It's injected under the skin every 4 to 12 weeks. Again, we wanted to bring you the ESMO guidelines for endocrine therapy in early breast cancer. So we summarize what we have been talking about. The definitive choice of agents depends on relapse risk, tolerability, bone health, and patient preference. Patients who have been on endocrine therapy for 5 years are likely to know well how they tolerate this drug. And this is really important to consider whether to continue or not a treatment. But while these drugs block the mechanism of luminal A and luminal B tumors to grow in the breast, they also block estrogen receptor everywhere in the body. So side effects are very much related to this. So if we talk about the side effects from tamoxifen, as tamoxifen blocks the estrogen receptor in the breast, it can also act like that in other organs, such as the uterus or the bones. So most of the common side effects are similar to menopause symptoms. So patients can experience hot flashes, vaginal dryness, bone pain, reduced libido, difficulty sleeping, mood swings. And these side effects, they are not serious, but they cannot be disregarded. They are so uncomfortable that many patients stop taking treatments because of this. So because, as we said before, actually taking tamoxifen can reduce the risk of recurrence up to 50% comparing to those that do not take the drugs, we really have to talk about this. We have to be open about little side effects that are really important for patients, even if they don't bring them to the ED. But other side effects are much more serious, but less common, as for example, risk of blood clots or increased risk of uterine cancer. A modest increase on endometrial cancer in postmenopausal women has also been documented on women taking tamoxifen. As I was saying before, thromboembolism, so blood clots, it's a side effect that we speak about a lot, especially in premenopausal women, as the risk is even higher. The most important thing with this is for patients to recognize the signs and symptoms. So they should be made aware of the symptoms so we can treat them promptly. So if patients suddenly suffer from shortness of breath, chest pain, redness in the calves, or swelling, they seek help. Normally, we do not give treatment to reduce the risk of blood clots because, as I was saying, it's not a common side effect. But if it occurs, we do give blood thinning injections. And for uterine cancer, we have to be very clear that if they see any abnormal bleeding from vaginal bleeding, women should be reviewed by a gynecologist specialist. Now we're going to move to the side effects of aromatase inhibitors. And aromatase inhibitors normally have less side effects, menopause related, but patients may present severe muscle pain and severe joint pains. Again, it may be something that doesn't drive them to run to ED, but it can be so uncomfortable that patients stop treatments. The wrist, the hands, and the knees are the most commonly affected areas. Another side effect from aromatase inhibitors is bone thinning. Low levels of estrogen can cause bone thinning, and this can lead to osteoporosis and fractures. Aromatase inhibitors are also related to increased risk of cardiovascular events. They can cause high blood pressure, and they can cause cholesterol rise. We normally monitor the cholesterol levels, but we don't need normally to give treatments to decrease these cholesterol levels. And some people may also experience hair thinning that can cause concerns to people taking them long effects as really affect their images. And when we speak about management of these side effects, patients prior and during treatment with an aromatase inhibitor should include bone density scan, and if needed, they will be treated with bisphosphonates or denosumab. Patients are also often advised to take calcium, vitamin D supplements to reduce the effects of the bone. For pain, we can give analgesics. Overall, endocrine treatment leads to a decrease in bone mineral density. This is observed even more in premenopause patients who get ovarian suppression. And as I was saying before, we can pair it with alendronic acid, which is a bisphosphonates, and has also some activity in preventing disease progression. So the next medication and treatment that I'm going to talk about is bisphosphonates. Bisphosphonates, such as I was saying, zoledronic acid or denosumab, are recommended on postmenopausal women or in premenopausal women having ovarian suppression, either with an aromatase inhibitor or tamoxifen. Bisphosphonates are a bone-modifying agent that improve bone mineral density, helping to decrease treatment-related bone loss, and therefore, it can reduce osteopenia or osteoporosis. That is, as I was saying before, a common problem for these patients. It is effective lowering fracture rate in postmenopausal patients receiving an aromatase inhibitor, and therefore we recommend in patients that have treatment-related bone loss. But it's also used as adjuvant treatment in systemic therapies, as has been demonstrated that the addition of bisphosphonates reduce the risk of bone metastasis in high-risk patients and improve survival in postmenopausal women. So it's not only a medication that we give to prevent one of the side effects of another medication, but also to help as an adjuvant treatment. Bisphosphonates do not usually cause side effects, or they don't cause serious side effects. The most common side effects are nausea or flu-like symptoms. Additionally, some studies have identified atrial fibrillation, and this may increase the risk of a stroke. But there are also a very well-known but rare side effect, that is osteonecrosis of the jaw, that it's thought to be caused by trauma to dental structures that, due to the effects of the biphosphonate therapy, have limited ability of bone healing. So for these patients, when they start biphosphonate, we normally recommend a dental review prior to start this therapy. You can see an example of a radiotherapy with osteonecrosis of the jaw here on the left. We have been exploring all treatments we can give for people with early breast cancer over the today and the last day, and some of the side effects of this treatment. Now we want to stop and talk about some of the emergency situations with some examples of problems related to the treatment. Because many of the side effects that we have been saying, they are mild or they are manageable at home. And most side effects can be treated after or even can be solved after treatment is completed. But nearly half of the women treated for early breast cancer have at least one severe side effect during their treatment. The reason to go to an emergency service, it can be due to a comorbidity, for example, a spike in blood sugar, cancer-related, so a spinal cord compression in advanced breast cancer, or treatment-related. That are the ones that I'm going to be talking about today. The most common and most known side effects are due to chemotherapy treatment. And it's also the most common visits to the oncology emergency department, so to all the acute oncologies. That study says that around 60 to 80% of the emergency visits are due to chemotherapy. We may see a shift on this as we are starting to do more and more targeted treatments and other treatments. And in chemotherapy, the number one risk is neutropenia due to the risk of infections. Febrile neutropenia is the development of fever with other signs of infection in a patient that has neutropenia. An abnormally low number of neutrophil count in the blood. Teresa did mention this when talking about chemotherapy. And despite major advances in prevention and treatment, febrile neutropenia is associated with the intensity of chemotherapy and remains one of the most frequent and serious complications of cancer chemotherapy. The most important thing here, once again, is prompt recognition of a potential infection. Patients need to know that even if they have a low-grade fever, this can be really dangerous for them. They don't have the same mechanism of defenses due to the chemotherapy nadir. So a fever in a patient in chemotherapy is always considered a grade 4 side effect, the most urgent one, until at least we know the neutrophil count. In emergencies, we triage patients and risk depending on the grade. And grade 4 is the most serious, as grade 5 would be the patient is already dead. And after the recognition, well, the most important thing after recognition is the reaction that we have. Patients need to have broad spectrum antibiotics within 1 hour. In a world where we are trying to avoid antibiotics due to antibiotic resistance, in this case, we are thinking about giving antibiotics as soon as possible. We should also think about asking questions. It's important to know what chemotherapy they're having, how long they have been having it for, how long ago was the last treatment, if they have any allergies, especially any antibiotic allergies, if they're taking any other medication. And as well, we have to question if they have any signs of infection. And so we can think about the possible places of infection. We can also think about if they have recent surgeries, as a breast cancer patient may have had, or if they had catheters. Once in the hospital, we really monitor them as they may become unwell very quickly. It's important to look for hypotension and fever and all the signs that you can see here on the right side, as the patients may become septic very quick. We do need to do blood tests and blood cultures on the patients. But the truth is that oral antibacterial therapy can substitute the intravenous treatment if we then identify that the patient is low risk, as long as they are stable. Here we have the ESMO guidelines that indicate us when can be appropriate to move to oral antibacterials or to have IV antibacterials. If the neutrophil count is more than 0.5, the patient is asymptomatic, has not had a fever for more than 48 hours, and the blood cultures are negative, then we can change to oral antibacterials and we can actually send the patient home. We also have to remember that this is a common side effect. So if the patient the patient neutrophil count goes very low after the first cycle of chemotherapy, we may prescribe prophylactic G-CSF to try to increase the neutrophil count while they are on chemotherapy. Let's move to another emergency, heart problems. Many early breast cancer survivors have more than 65 years old and have other comorbidities such as hypertension, diabetes, left ventricular dysfunction. And many of the medications that we give can cause cardiac toxicity. That, added to the comorbidities, makes it important to consider heart problems. Common manifestation of treatment-induced cardiotoxicity can include cardiomyopathy, ischemia, conduction disturbances, hypertension, thromboembolic events. For example, we have talked about anthracyclines, and they are well known for the cardiovascular events. The most frequent side effect of taxane is sinus bradycardia. Trastuzumab has also been associated with cardiac failure, and in this case, it's reversible, not like anthracyclines. But the manifestations are not always very obvious. It can present as ECG changes. So it's important to do an ECG to a patient that feel fatigued, that feel unwell with specific symptoms. And it's also important to start surveillance before, so we can have a baseline measurements of each individual for the blood test and even for the ECG. I would like to emphasize the reason why I bring this here, how important is that we, nurses, are able to see changes on the ECGs and that we compare blood pressures. We just don't take them and note them. And more importantly, that we listen to our patients and ask their problems. I will also add that cardiac problems, one of them can be atrial fibrillation. And AF can translate to a clinically relevant stroke risk for many early breast cancer survivors. And that, if we add it to the hormone treatment that may increase the risk of blood clots, bring us to my next emergency, thrombosis. Blood clots. We have mentioned that tamoxifen is associated with increased risk of thromboembolic events. And venous thromboembolism is primary and leading preventable cause of death worldwide that comprise both deep vein thrombosis and pulmonary embolism. Once again, early recognition of these symptoms are key, and patients and us should be aware of them. What are the signs and symptoms? I'm sure most of us know, but it's really good to have images like this one to try to make very clear the signs and people to remember these signs. For DVT or deep vein thrombosis, it can cause swelling, pain or tenderness, increased warmth or cramps or pain in the area that is swollen, or red or discolored skin. It's very common in calves. It can also occur in arms when we put a catheter in. And if we move to pulmonary embolism, the common signs and symptoms are shortness of breath, pain when deep breathing, tachypnea, and tachycardia. We have to be very careful with patients with risk factors. And we have to think about as well the most appropriate diagnostic test, because some of the things that normally are done on cancer patients are not that good for cancer patients. So if any patient have any of these symptoms, we should think and consider, look or ask for an ultrasound to see if they have any blood clots. Treatment of VTE normally includes anticoagulants that can be injection or orally, and we may maintain that treatment for at least 6 months. I put this image before, and in this graphic, you can see that some of the side effects, the most common side effects we have been talking about. But another common visit to emergency department is something that we don't give much importance to, that is GI complaints, so gastrointestinal problems. So I want to bring up again this one, especially talking about diarrhea in patients having targeted treatments. So chemotherapy can cause diarrhea. Bisphosphonates can cause diarrhea. Targeted treatments can cause diarrhea. So it's quite a common side effect. In the case of patients receiving targeted therapy, in especially one called neratinib, diarrhea is reported in more than 80% of them. And this is one of the targeted therapies that is used in HER2 positive patients. Diarrhea can be severe. And if it's not properly managed, it can lead to dehydration, dose reductions of medications, treatment interruptions, or discontinuations because patients may stop taking them. In order to effectively manage this diarrhea, we require to understand really what's going on. So the incidence, how severe it is, how long has it been going on, and the duration. Because if it's mild, so uncomplicated cases, as we would call the 1 or 2 grade, they can be managed effectively with antidiarrheal agents. You may know loperamide as one example. Loperamide acts as an agonist on opioid receptors, decreasing gut mobility and therefore helping them to control the diarrhea. But patients that have more complicated cases require more aggressive management. That may include them coming to the hospital, stop the treatment, and maybe start at a reduced dose, as well as giving antidiarrheal therapies. Medically complicated diarrhea can be associated even with GI bleeding. So we really need to evaluate, treat, and follow up these patients. In some cases, such as patients that are taking neratinib, the targeted treatment that I was talking about, actually going home with some prophylaxis anti-diarrhea treatment, it's considered and it's given. This is not all the emergency situations. This is just an overview of them. But actually, we think that it's important for us to consider that a part of this, we have been talking a lot about side effects that were not bringing patients to hospital. So we are going to talking about now the side effects and the assessment of the side effects. A study from 2017 collected and analyzed data of the frequency and severity of toxicities associated with cancer treatment in women with early breast cancer. The study was called ICAN Care. It was done on the US, and they surveyed patients 2 months and 7 months after diagnosis. And patients were rating severity on different toxicities: nausea and vomiting, diarrhea, constipation, pain, arm edema, dyspnea, breast skin irritation, so some of the most common ones. And the results speak for themselves. 93% have at least one side effect. 45% of them had one severe or very severe side effect, where pain, skin irritation, and constipation were the most common. 9% of the patients had an unscheduled doctor visits because of the side effects. 5% visited an emergency room because of the side effects. And in that study, they also look at combination of treatments. Patients who receive chemotherapy and radiotherapy had 30% higher odds of having a severe toxicity over the patients that had only one treatment. So this is important. And this important progress in adjuvant treatment, it's telling us as well how we're treating patients. We now have more effective therapies. We are able to target better the tumors. But while the advances are helping us to decrease the overtreatment, such as, for example, we don't do that many mastectomies when they are not needed, in reality, many of these patients are on combinations of treatments. And all of this progress has translated in better survival, but as well, it's associated sometimes with deterioration of quality of life. And it can also come with longer and late side effects that we are learning how to mitigate. From all the issues that patients may experience, what do they complain the most of? Well, 70% of patients complain of musculoskeletal health problems. That can be, for example, pain. 66% complain of central nervous system health problems. That can be memory, concentration impairment, fatigue, reproductive system health. It's another really important concern. Around, well, a little bit more than 50% of the patients complain about this, as well as problems related to the breast and psychological health problems. So when we look at all the treatments we use, we know that they have some side effects, but we have to really think about them. Local therapy, chemotherapy, biological agents, hormonal therapy, all of these that we have been talking about. We know that they have some short and late side effects and that they are different for type of treatments. We have covered most of the side effects. We know more or less a little bit about the management of this. We know that there are several studies looking at this. These issues cannot be neglected. Surgery can cause pain, lymphedema, restriction of the movement of the arm or the shoulder. Hormonal therapy can cause hot flashes, joint pain, bone thinning, fractures. Chemotherapy can cause hair loss, diarrhea, mouth sores. Radiation therapy can cause pneumonitis. We speak about them separately. We have many efforts to decrease these side effects, to give supportive methods. But something that we need to think about, it's that most of the time, we don't give them alone. It's not a standalone problem. Toxicities do not occur as solitary events. They normally result in clusters of symptoms that they have common biological etiology. We already spoke about the combination of surgery, radiotherapy, systemic treatments, but they are almost in order, almost always, and not at the same time. But many of the systemic treatments that Teresa and I have been talking about today are combined at the same time. Unfortunately, they are wonderful ways to target the tumor. But, for example, if we think about the cardiac toxicity that I was speaking about, an emergency thing, the risk is higher when you are having trastuzumab in combination with anthracycline chemotherapy, and it happens. So with this example, I wanted to remember and to think about that the combination of treatment can cause two things: accumulation of side effects or exacerbation of this. An example of exacerbation can be acute fatigue. Fatigue is a universal symptom during cancer treatment. We all have heard about fatigue as an acute symptom, and is seen both during cancer treatment and after cancer treatment, normally around 6 months after completion of therapy. and it can be really exacerbated in combination of treatments. Another example, in this case of an accumulation of side effects, can be the gastrointestinal toxicities, as they tend to cluster. A patient may have simultaneously nausea, vomiting, diarrhea, and mucositis. What makes this much more difficult to manage. But if we think about one of them, diarrhea, it may also be associated with symptoms related to the diarrhea. Cramps, bloating, and an urgent feeling that you need to have a bowel movement so you don't really leave home. In webinar 3, we will talk about the management of some of these side effects, such as fatigue or menopausal symptoms or the bone health. But today we wanted to think about the side effects. And when talking about side effects, we need to consider individual risk factors and possible complications that can tell us that it may have a poor outcome. So we need to consider the patient-related factors that can include things like comorbidity, their lifestyle before and while on treatment, their genetic susceptibility, patient desires, and we also have to consider treatment-related factors, like what is the patient actually having? And we also need to remember that all of those side effects, treatment, shock, change your life, can also disturb our patients' physical and mental health. So early breast cancer treatment, it's very effective, but take a real toll on patients. By now, it's quite clear that most of the symptoms patients get are vague. They may feel that they are expected, so they don't seek for help. But for this reason, because they don't normally seek for help because they normalize it, it's very important to know, for patients to know what treatment they're having, what are the most common side effects and most dangerous side effects that they may get, who they can ask for help. So if you have an acute oncology department in your hospital, the number of this, or the link nurse, or if they need to go to an emergency department. And if they go to an emergency department, they need to know that they have to inform the nurse doing the triage that they are on treatment for breast cancer, so they know the possible problems from it. And most importantly, we need to tell them that we are here for them, that we are here to support them, to help them, not just to give treatments. I also like to remember the importance of education and prevention, and this is mainly what we have been talking about today. So we need to be able to assess our patients. And the comprehensive assessment of symptoms is an essential component of care with people with cancer, but especially with early breast cancer, that we don't routinely do. Accurate symptom assessment is needed, and it's the only really good way to see the needs of the person, how these needs change, and to improve their quality of life. When assessing the patient, we have to think about their current functional level, the symptoms they are experiencing, the treatments they're having, and the side effects that they may develop. So the same things that we have to tell the patients, we need to know as well. It is very helpful to use a structure measure, and these help us as well to compare how the things go along the treatment. And actually can empower people, own patients, for telling you early detection and their own monitoring of their symptoms. And it can help us to have a deeper understanding and act on person needs. We can use the distress thermometer, that is the one image that you have here on the right side, or we can also use some patient-reported outcomes measures. The use of these will help us to have a better knowledge and understanding of the different symptoms and how they can occur in combination or influence each other, and allow us to understand what really matters most to the patient. It can help us as well to enable us to treat a symptom, not only in isolation, but when they are in cluster. It also helps to reduce polypharmacy, to reduce side effects and improve patient quality of life, and establish good symptom control early on so the patient can feel trust, a good therapeutic relationship, they actually continue their treatment. And it can also help us to get a better relationship between the family, the staff, the patients, so to really work as a team. In order to do that, we need to know our patients. Again, we need to know what treatment they're having. Again, we need to know what side effects they're having. And that's what we try to do today for you, to give you a little bit of knowledge about all of this. To remember you, toxicities cause many problems. Toxicities may lead to treatment discontinuation. They are very costly because they increase service use, and they can also cause premature death. These symptoms play physical, emotional, and financial burdens on patients and their families. And this is why we need to be prepared. And I hope this is one of the reasons why you're here today. So it's clear that treatments have a negative impact in many domains of the quality of life, but it has a lot of positive impact on the treatment of cancer. The impact of chemotherapy and endocrine therapy, it's very different. And we also have to think about the situation that patients are. We have to think about how different it will be in women that are thinking of having children versus those that, for example, have finished their family. But it has sexual impact for everyone. Things like sexual enjoyment, body image, that are problems that are highly reported, as we said before, on the study in patients. And it can be for premenopausal women or postmenopausal women. We don't have to disregard people that have finished their family because they still want to have a normal sexual life or what is normal for them. We know that postmenopausal patients report more problems with functional and social functioning. So today, we have talked about all the different treatments and different characteristics of the patients and how these can play different roles in the quality of life and the symptoms and in the function that can impact the cancer experience in general. Another thing that we need to take into consideration is the result of many studies that suggest that healthcare providers tend to underestimate the frequency, severity, and impact of most treatment-related toxicities. So for today, and as the end of today, remember, we are here to help, to support, and to improve our patients' life by addressing the things that matter to them the most. We hope that you will come to our next webinar, where we will be talking about the impact of early breast cancer, many of the signs and symptoms that I have been talking about today, and how to manage it, and living well during and after treatment. We have now time for some questions, so please make this a little bit of a debate, and it's time for us to stop speaking and for you to speak with us. Thank you very much.